أعوذ بالله السميع العليم من الشيطان الرجيم. بسم الله الرحمن الرحيم. Dr. Adnan Bhai, can you hear us?
Yes.
All right. Um, Jim Sagla, welcome to the monthly SBMA webinar series. This month we have Dr. Adnan Bhai Rafiq. He is an internist in Houston. When Dr. Adnan Bhai, I asked him about himself, he mentioned his family. Um, he mentioned that he has a big family. He's been blessed with four children. And similarly, in his career, he also deals with some very big problems, namely obesity, cardiovascular disease. He also owns a med spa, and he has a lot of creative solutions for his patients who are dealing with obesity. And we are very honored to have him on today. So, Dr. Nanbai, very briefly, if you want to tell us a little bit about yourself, how you got into this, and yeah.
Oh, thank you for the introduction. So currently I'm living in Houston. And as I'm in Houston, we're in Texas, and everything is big in Texas. So, including my patients. My patients were requesting or needing assistance with helping them with their cardiovascular disease, diabetes, hypertension. We were treating everything. And I felt that one of the biggest things that we were treating, we were being reactive to their medical issues and not being proactive. And we felt that, starting looking at treating the obese individual will help them with their other medical issues. And so that's kind of where it started from. But I've always been intrigued and interested in all the different new modalities and different things that are coming out. But as you mentioned again, yes, I have a large family. We have four children in Houston. It doesn't feel so large. Pretty much everybody here has four kids. So we are a normal American family in Houston. Um, and then on the spare time when we're not when I'm not working, we are trying to travel. We go to sporting events, try to be outdoors as much as possible, and just enjoy where we are.
Yeah, yeah, that sounds extremely lively. So tell us a little bit about what you mean when you say obesity, thinking outside the lines.
Okay, so we have a lot. Well, there has been a lot of medication in the past studied regarding obesity and to help um, obese patients. However, recently there have been a lot of newer medications that have come out, and not only medication, but also supplements that have been that are being used to assist in helping these patients achieve their goals of losing weight, improving their health, regulating their diabetes, things like that. And so not only do we use the normal medications that we have, whether it be phentermine or Contrave, and then we have the newer ones, which are semaglutide and tirzepatide, which pretty much everybody is wanting to be on. But we go outside the lines. We think outside the box a little bit. We try to help our patients if they are still struggling with hormone replacement therapy. We also help with, we'll have them use peptides to assist in trying to achieve their goals. And so, from that perspective, I think, we're just thinking outside the lines when it comes to obesity. So that's kind of what I wanted to start with, but we will kind of move forward. Um, is it okay if I kind of start?
Yes, absolutely.
Okay, so this talk, we will kind of go over the BMI. That term is used very frequently, and um, with regards to the general population, but we'll try to see what it means for our South Asian population. And then we'll go into weight management approaches. There's behavioral approaches, and then there's also adjunctive medications, which we use. And also with medications, there are also, um, as we mentioned, different modalities that are not necessarily prescribed and kind of received from your local pharmacy. And then we'll go into some cases. So let's start with how many of you had parents that ate healthy, exercised regularly, and ate dinner early? Um, and so some of you who are on or are watching may have heard this before, and so I've done this talk a few years back, and I'll try to kind of change it up. And if you have any questions, please ask. We'll try to keep this as interactive as possible. And I hope that you don't feel like you wasted an hour on your Saturday night listening to me talk. So this is our parents, uncle, auntie. This is who we, for the most part, kind of saw growing up. We didn't really discuss weight management or discuss eating healthy, discuss low carbs, high protein, things like that. So let's just kind of go into percentages. Start with people who are overweight, about 30%, 34% men, 27% women. Um, People who are obese, and we'll go into the difference between obesity and overweight, as well as severe obesity. About 42% of all women are considered obese. Um, and so we'll go into this a little bit more as to what that means with our patient population as we treat patients moving forward. Um, so, as shown in the table above, again, 1 in 3 adults are overweight, 1 in 3 men, and more than 1 in 4 women are overweight. More than 2 in 5 adults uh, have obesity, which includes severe obesity, and then we'll go into that. And so as we move forward, as defining what obesity is, it comes down to the BMI. And so the WHO classifies obesity or BMI in different categories of weight management or weight based off of the BMI. And so we ideally feel that anyone who has a BMI of 18 to 24 kilograms per meter squared are are normal. They're not overweight, they're healthy individuals. If you are overweight, your BMI is 25 to 29.9 kilograms per meter squared. And if you're obese, you have a BMI greater than 30 kilograms per meter squared. And then we have morbid obese or severe obesity, which is greater than 40 kilograms per meter squared. And this is in the general population, which was based off of white males. However, the WHO also has an Asian BMI classification, which is a little bit more strict. And we'll go into the reason as to why that is more strict. And so if you look at one who is overweight, who is from the Asian or Asian subcontinent, they're considered overweight with a BMI of 23 to 27.5 kilograms per meter squared. And then they're considered obese if they have a BMI greater than 27.5. And so the reason for this is because we found that um, if we look at central obesity, basically adipose tissue, visceral adipose tissue, around the midsection, this leads to a lot of medical issues within our population. When I say our, I'm talking about the South Asian subcontinent. It leads to insulin resistance. It leads to diabetes, dyslipidemia, um, coronary artery disease, as well as left ventricular dysfunction, as well as hypertension. And people who have seen this talk before may also recognize some of these slides. I've borrowed some of these slides from a fellow physician just to uh, um, to give credit to his work as well. But this comes from the International Journal of Obesity. So this tells us that BMI is one indicator, or it gives us an idea, but really, essential obesity in the South Asian population is really what causes a lot of medical issues, and that's why the BMI is so strict and is lowered because greater BMI will allow to greater central obesity, hence leading to higher medical issues, as we just talked about, diabetes, dyslipidemia, CAD, and such.
Sorry to jump in here, but just a personal question from me. Do you think that a lot of primary care providers in the US are aware of these different BMI standards for Asians?
It's a good point. Honestly, I'm not 100% sure on that, and I haven't actually talked to people about that. But I mean, that brings a valid point. And it probably comes to the fact that depending on who you are, meaning if you are an American physician who practices and you're not necessarily really focused on obesity, you may not even know that there is a different standard per se for the Asian population. This is definitely discussed in anyone who is learning more about obesity or obesity medicine. There are a lot of physicians who are becoming obesity medicine boarded, and that is definitely discussed. But in the general population, as far as physicians are concerned, it's a valid question, and I'm not sure if people do recognize that difference. Then that's a good question. So moving forward, if we look at BMI, and one of the things with BMI, we know that it's not 100% accurate. It's not the best tool that we have, but it's one of the tools that we have. And there are other tools as well. We can look at the waist to height ratio. This was discussed in the NICE guidelines for adults with a BMI less than 35 and children's greater than 5. That's when it would be beneficial. And a waist circumference to height ratio of less than 5 would be good. There's also tools of looking at impedance, resistance of low voltage current through the body, and that helps us determine whether or not they have a lower or higher fat mass or body fat percentage. Um, the gold standard, however, is DEXA studies. It looks at the obesity and it looks at the body fat percentage greater than or equal to 25% for male, and it should be less, or if it's greater than 32% for females, considered obese. We would like, obviously, our individuals to have 10 to 20%, whether it's male, or 18 to 28% for females, based off of the DEXA scan. And then this can be checked on a regular basis to show improvement, right? These tests that we consider or we do, if we do them once, it gives us a baseline, but then doing something with these studies and showing improvement is what we really want to focus on. Um, Again, well, now with the DEXA scan, the issue is cost. Um, and to a certain degree, you cannot quantify subcutaneous versus visceral fat. And so that's important because subcutaneous fat, it's subcutaneous. It's not causing you much issues with regards to medical issues. However, the visceral fat, the visceral adipose tissue is what causes and drives the cardiovascular disease, the insulin resistance and diabetes, as well as dyslipidemia. And so that's really what we want to focus on when we discuss, obesity, is really looking at getting rid of and decreasing the visceral fat. I think something just happened. Can you guys still?
Yeah, I'm sorry, there was a quick problem. Give me 1 second, please.
Okay.
Okay, you should be able to share your screen again.
Okay. Is that we're good?
Yep.
Good, good. So moving on, weight loss. This is what we really are here to talk about, and the road to weight loss. that's what we really want to focus on, is that weight loss is not something that we discuss and we make changes for a month. It truly is a journey. This is something that people have to make lifestyle changes, behavioral modifications. There also has to be changes with regards to your thought process and what you do. And sometimes it's not even only you that have to make changes. These changes need to be sometimes even should be with family members, whether it's your significant other or your children. And that's something that I think is extremely important as we move forward with regards to this weight loss journey for our patients. Okay, so cost of weight management or obesity. So according to recent studies, it's estimated that US is projected to spend over $385 billion on obesity-related healthcare costs in 2024. And this was reflected and anticipated the growth of overall healthcare spending. The market for anti-obesity medications reached a major milestone in 2024 with a global spend exceeding $30 billion for the first time. And this is an over tenfold increase just from 2020. So in 4 years, tenfold increase, now we're exceeding $30 billion in global spend for weight management medications. Okay, so I'm an internist, and so I treat adults, anyone from the age of 18 and up. Um, However, understanding childhood obesity is very important as well in regards to knowing your patient. And so studies have shown that childhood obesity is linked to adult parental obesity. So if I have both parents are obese, more than likely their child is going to be obese, and then this epidemic continues. As the child becomes obese, then their children will be obese, and so on and so forth. So we really want to focus on weight management as soon as possible, and not allow it to get past into adulthood. Um, so again, as mentioned here, having two obese parents, the child is 80% likely to be obese. So factors that play a role in obesity, we have genes possibly, which are being studied as we speak. We have the environment. We have stress and mental health. We also have sleep, lack of sleep primarily. Um, and we'll go into this more. So what do we know? And this is what we know thus far with regards to obesity. That we need to treat obesity to help our children. As mentioned, both parents who are obese, there's an 80% likelihood that the child will be obese. Sleep. It has been shown that getting appropriate amount of sleep helps lose weight. And so if you are doing all the right things, you're um, eating well, you are exercising, but you're not getting enough sleep, or you are not managing stress properly, you may have some hindrances to weight management. So sleep is very important. Exercise. So it has been shown that getting around 150 to 200 minutes per week of moderate intensity exercise has been shown to maintain one's weight and to help prevent one from becoming obese. Um, Having a low carb diet, having a high protein diet, these things have been beneficial and shown. And we know there's multiple diets out there with regards to a high protein diet. The ketogenic diet. There's the Atkins diet, South Beach diet. I believe there's even a Galveston diet here in Houston or close to Houston. Um, and so there's so many diets, and they all have one thing in common. It's increasing your protein so that you can get into a ketogenic state, which is great. And we know that ketosis allows us to lose weight. But the problem is sustainability. And so having a low carb, not a no carb, high protein diet is beneficial, right? So a low carb diet is sustainable. And that's really what we want to focus on, is sustainability and appropriate lifestyle changes for the long term. Um, Also, eating 2 to 3 hours before we sleep. An arbitrary number that we have for cutoff for eating dinner is by 7 p.m. And the reason is that the average population sleeps by 10:30, 11 o'clock. And so if they eat by 7, they have it 2 to 3 hours prior to going to bed, they can digest their food appropriately. And knowing on average how many calories one should be eating. We have this thought process of eating a 2,000 calorie diet, when in reality, it should be less than that, actually. Again, it depends on your activity levels, and that has to be calculated. But a rough estimate for women, 13 to 1,500 calories per day, and I didn't put here, but for men, about 15 to 1,800 calories per day should be appropriate for maintaining weight. All right, so moving forward, we have the behavioral approach, which we've been talking about is, exercise regularly, make it a habit, right? And so when we talk about behavioral approaches, we're talking about primarily habit forming things, eating less processed food, getting at least 7 hours of sleep, trying to eat on smaller plates so that you have a habit of decreasing your portions. Eat slowly. Don't eat until fullness. So this, it takes about 20 minutes for the satiety hormones to signal to the brain to stop eating. And so if one eats slowly, they don't overeat. So now we'll get into like the meat of the discussion or the talk. It's basically adjunctive medications, and I use the word adjunctive because I really focus with my patients. I really focus on lifestyle changes, and I want them to think of medications as truly as an additive to help them get to their goals, not necessarily as the main driving force for their goals and their weight loss. Um, and so we have medications, and we'll go over some of these medications rather quickly, but to show that there are lots of medications that are out there. We have some newer medications that are really have been taken the medical family by storm, and almost anybody who is practicing probably has heard of some of these medications or not has prescribed them. And we can even discuss, even though this is not in the realm of obesity, but there are some of these medications are, from a weight loss perspective, are also being approved for other things that are associated with weight, with regards to obesity. And we can get into those a little bit more as well. There's hormone replacement, which again, I have found this to be very beneficial to some of our women as well as men who lack the energy levels to do things. So these aren't direct benefits as far as weight management from a hormone replacement standpoint, but they help in an indirect standpoint, and some direct standpoint as well. And then the newer tools, I guess you can say, in my toolbox are peptides. There are a few peptides that we use. There are thousands of peptides in the body, um, but as we are moving forward and studying these peptides, some of them are used for so many different things with regards to muscle repair, with regards to um, clearer cognition, with regards to weight management and lipogenesis, or inhibiting lipogenesis, and causing a lipolysis. So some of these peptides have been beneficial as well, and sometimes used synergistically with some of the other medications that we have. So I'll start off with, given that I um, do a lot of outside the norm, I guess you can say, or I do some outside the norm management. I do use compounding pharmacies. And I know there's been a lot of discussion about compounding pharmacies as far as their role in causing complications or causing side effects of medications, and that you should only be prescribing um, I guess you can call it brand at this time, medications. Um, but I feel if you have the right compounding pharmacy, a vetted compounding pharmacy that has done their due diligence, knowing how to use them appropriately has been very beneficial for us. they play a huge role in allowing the population to benefit from medications that either they can't get because their insurance doesn't cover it, or if they're underinsured, it's just too expensive for them to pay out of pocket to your local pharmacy to get medications. And so compounding pharmacies are definitely cheaper. Um, and to my understanding, and I may be incorrect, but I believe Medicare at this time does not cover any anti-obesity medications or anything for weight management. And so those are all out of pocket. Um, there are different types of compounding pharmacies, 503A, 503B compounding pharmacies, which, again, 503A, just to a brief introduction, 503A are basically pharmacies that are able to prescribe to patients. So you can write a prescription, and those pharmacies can then provide those prescriptions to patients. 503B compounding pharmacies are primarily pharmacies that are provided to the practice or to the physician's office for the office use. And so you may get certain medications. Recently, I can tell you that, well, not recently, sorry. Recently, I was told that semaglutide may be able to be written or prescribed via the 503B compounding pharmacies for office use. And so that's something that may be coming down the future, and we can talk about that a little further down. Um, and then also knowing where these compounding pharmacies are licensed and what states they can send to. And so I have a very good compounding pharmacy that I use currently in Houston, and they have a pretty wide range of licenses that they can send across the country. And so that's very helpful as well. So we'll start with some medications. I just put up a few here, but we'll go through many more as well. And we can start with phentermine. Phentermine, one of the oldest medications that we have. Um, and I will not belabor the point on a lot of these medications as we probably know them all, these older ones for the most part. But just with regards to phentermine, because it's still used very, very frequently, the main thing with phentermine that I would like to inform people is that it should be used in a short-term use. And the reason for that is because it has some potential side effects. And I believe it's on the next slide. Yeah, so it does have some side effects, which it could cause some cardiovascular issues. It can cause tachycardia. It could even cause pulmonary hypertension as well. And so we have to be very careful when using these medications as far as what contraindications they may have. And then also knowing that with regards to phentermine, the efficacy is about 5 to 15% total weight loss, which is not bad. But the main thing is we normally see people really have a benefit about 5% because they develop some form of, I don't like to use the word tolerance, but the medication is not as effective after being on it for a few months. Um, and so this is the most important thing is here is to focus on short-term use for this medication and then to cycle them off for at least a month to 2 months before possibly getting them back on it. And so this can be used for over a period of time as long as we cycle off this particular medication for a period of time. Um, we have orlistat, which is a very old medication. We rarely use this anymore. It's a reversible inhibitor of gastric and pancreatic lipases, and it inhibits absorption of dietary fats. And so, if you recall, orlistat causing issues with diarrhea and things like that in the past. Again, we don't use this very, very frequently, and the amount of weight that we were seeing that were being lose was very minimal, especially now that we have new baselines compared to the newer medications that we have there and that we have available to us at our disposal now. So then we have phentermine and topiramate combination. This is quite costly when we in regards to it when we're talking about a capsule. And so if we we use it separately. We actually write for phentermine and topiramate separately, which ends up being a lot cheaper than writing a combination tablet or the brand. Um, and so the main thing I want to get from this, I want you to understand this, is that it can be costly as far as the actual tablet is concerned. But if you write for them individually in separate, they it's definitely a lot cheaper. And the way we practice and use this particular medication is we recommend using phentermine in the morning because it is a stimulant, and then using the topiramate in the evening as it can cause some drowsiness. And so we recommend using this at nighttime. And so if you split the two medications, you can take one in the morning and take one at night. And also gives them a little bit more of a 24-hour coverage as well. Again, from an efficacy standpoint, approximately 8-9%, which is not bad. It is very person dependent with regards to this. And also keep in mind, given the fact that we're using phentermine, we definitely don't want to use this also long term with regards to the potential side effects of this medicine. So then we have naltrexone and bupropion. Um, this is the brand name is considered Contrave. Um, it's come out in 2014. Definitely this can be used for long-term use, but we have to be careful given that there is naltrexone in the compound with regards to who we are providing this for. We definitely do not want to provide this to our medications or sorry, to our patients who are or have chronic pain, who are taking chronic opioids by their pain management. So we have to be cognizant about, again, who we are prescribing this medication for. And this is also quite costly as well. Um, now, and as we move on, we'll see some other medications that as we see. So with regards to Contrave, even though this can be used long term, the efficacy is just not there. That with regards to seeing a profound amount of weight loss, and we just do not see that with this particular medication. However, with that being said, some of these newer medications require um, some of these older medications to be tried first and failed prior to starting newer medications, which we see this with majority of our newer medications in any field of practice. Then we're getting into liraglutide. This is a glucagon-like peptide 1 receptor agonist, similar to the newer GLP-1 receptor agonist that we have. This was actually, when it was prescribed, it was primarily for diabetes, but then also started to use for weight management. However, this is a sub-Q injection that was given daily, as opposed to how what we currently think of our GLP-1 agonist given weekly. The dosing it started at zero point 0.6 and it would go up to 3 milligrams. This had a slightly better efficacy with regards to weight management, but given that this was a GLP-1 working on the gut, it caused nausea, constipation, and rare conditions of pancreatitis. Um, Again, family history of MEN2 syndrome, medullary thyroid cancer. These were contraindications to this particular medication. Um, and then we get into semaglutide, which we all know about today. We all know semaglutide and its benefits. We all know semaglutide and some of the side effects that it has. Now, so when we talk about semaglutide, it is also a GLP-1 receptor agonist. It slows the gastric and small bowel motility, improving satiety, and acts centrally as well to reduce appetite. So it reduces cravings. it reduces food noise that we call. This is a longer acting medication, and thus it is given weekly. Um, and the dosing goes from anywhere from 0.25 to 2.4 milligrams once a week. Now, one of the one of the things to keep in mind is that semaglutide, even though it is a once a week medication, some mild or some small tricks that one may notice or may realize as they discuss um, how their patients are responding to this medicine is sometimes they feel that after 3 to 4 days, the food noise comes back, the early satiety starts to get reduced. And so there are some things that we can do. Again, this is completely off label and it's not how the medicine was written for. But what we do is we cut the dose in half and have them take it twice a week. Um, so that's another thing that can be done with regards to semaglutide is reducing the dose and cutting it in half and having it administered either on a Monday and Thursday or Tuesday, Friday, however, but twice a week to maximize the benefit of the medication and the early satiety and the food noise. What we've seen with this is an approximately 15%, 15 to 20% reduction in weight loss. And so when we compare these medications from a medical standpoint to what we have from a surgical standpoint, people were realizing that are getting to a certain degree almost a decent response without having to go under anesthesia, without having to go and have surgery. And so people were opting this route a lot more. We've noticed our bariatric colleagues, some of them um, having to reevaluate how they practice. I can tell you from our standpoint locally, our bariatric team that is on our campus is really reevaluating what they can offer and how they offer it, just because a lot of their patient population is being diverted, lack of a better term, and using the GLP-1s, the GIP agonists, or GIP to help with their weight management. Um, so that's it's very interesting to see that from a medical standpoint, we are, I don't want to say definitely surgery is surgery, and the benefits are much greater than 15-20%. But there may be possible side effects, possible complications that arise anytime you undergo surgery. Obviously, I am an internist, so I'm a medicine physician, and I have my biases, as you can tell. Nonetheless, so semaglutide has been a great benefit to our patient population. We have seen tremendous improvement in weight management with regards to this. Again, some things that you may realize or see is the side effects of nausea and constipation. People also develop some gastritis after being on it for a while. Sometimes they even complain of having a foul smelling belch. Um, and so if one cannot get past the nausea, we offer, anti-nausea medications on Dansitron to help with that if the patients are requiring it. Um, Sometimes cutting the dose in half and doing it twice a week uh, allows them to better tolerate the medicine than taking a higher dose once a week. So these are things that you may want to consider or think about or look into if you're having issues with patient compliance or they're having side effects. Again, given that this is a GLP-1, the contraindications are definitely a family history of men type 2 and a medullary thyroid cancer. And again, we do not use this medication in pregnancy or in breastfeeding as well. And again, given that I'm an internist, we use this almost all of our patient population. But from a pediatric standpoint, there is a lot of work being done to use it at a younger age. But from my understanding, it's 12 and older at this point. Um, so tirzepatide is the newer medication, and this is a dual agonist. It's a glucagon-like peptide, one receptor agonist, as well as a glucose-dependent insulinotropic polypeptide. And so, as I mentioned earlier, we were talking about peptides, semaglutide, tirzepatide. These are also peptides. And basically, they have a strain of amino acids that has been used, but they have been these peptides have been approved by the FDA, whereas others to this point have not. But again, tirzepatide, semaglutide are also peptides that are being produced to benefit our patients. So again, tirzepatide, similar to semaglutide, slows gastric and small bowel motility, improves satiety. Now, the thing that I've noticed and that you may notice with your patients in regards with these two medications, tirzepatide and semaglutide, is that sometimes an individual, if they cannot tolerate semaglutide, they may be able to tolerate tirzepatide and vice versa. I can't tell you why that is the case, but I do know that I have individuals that cannot tolerate tirzepatide, but they don't have any issues with semaglutide, again, and vice versa. Um, Theoretically, the glucose-dependent insulinotropic polypeptide, the GIP receptors, are not, they do not cause as much nausea and constipation. It's more the GLP receptors that do. And so that's why tirzepatide, in theory, should be better tolerated. Um, Now, talk about efficacy. Similar to semaglutide, given that this is a dual agonist, dual receptor agonist, it has a little higher efficacy at 21%, and 26% the longer we're using this medication based off the SURMOUNT-4 trial. Um, Again, the contraindications are the same. And as with the efficacy as far as the longevity of it being given once a week. We do sometimes split this medicine in half as well for our patients, depending on how they're tolerating it. Now, tirzepatide, however, is not approved yet for the pediatric population, from my understanding, um, um, as opposed to semaglutide, that is. Um, so then we go to naltrexone. We talked about that. I apologize. Okay, so I'm just want to say, are there any questions or anything like that, Alibai, that you have come across?
No questions right now in the chat.
Okay,
For anyone else watching, you can always post any questions on the YouTube chat.
okay, great. Let's see here. So primarily, I just want to speak on my behalf as far as, what we're doing with regards to our weight management. We primarily are using semaglutide and tirzepatide. Tirzepatide, if you've noticed, is a little more costly than semaglutide. And so even from a compounding perspective, it is more costly. And so I want to state that semaglutide and tirzepatide, if not covered by the insurance. Well, let's start with this. I want to back up. I apologize. I want to back up a little bit. So semaglutide, um, the brand name from a weight loss perspective is Wegovy. And Wegovy is being studied or being approved or has been approved, sorry, for a cardiovascular indication. And so there may be cardiologists that also right for semaglutide um, from a cardiovascular, using a cardiovascular indication to also help our obese patients. So that's something that has recently come up within the past year or two. And tirzepatide has been approved for obstructive sleep apnea. So a lot of our sleep medicine physicians, our pulmonologists who treat sleep apnea, or even our internists for the matter, who treat sleep apnea can um, write for obstructive sleep apnea as the diagnosis and use tirzepatide in that manner. Even though it has been approved by the FDA, there are still some, we have to wait a little while for the insurances to catch on. But I can tell you that there are a few insurances that are approving tirzepatide or Zepbound, which is the brand Zepbound for obstructive sleep apnea, um, that will benefit them as well as their obesity as well. So just some other things that we're going to be seeing Wegovy and Zepbound most likely being FDA approved for other things other than just obesity, um, and be able to be used in our obese patients. Um, However, until that kind of comes full circle where we're able to write for sleep apnea and write for Zepbound, or all the insurances are approving without any issues. There are some individuals that are not able to afford $1,200, $1,500 a month of this medicine. And so compounding pharmacies, as mentioned earlier, do provide a great benefit to our patients to allow us to get this medication at a much cheaper price. Now, with that being said, you do have to vet your compounding pharmacy, and you have to trust them and know what they can and can't provide, and how they're doing their compounding. Um, and majority of the good compounding pharmacies are also involved in education. They also go to the A4 M meeting, which is the um, age meeting with regard. I forgot what it stands for. I apologize, but it's with regards to aesthetics and age, with regards to that. So a lot of these compounding pharmacies involved in that as well. Um, Again, just to give you a little bit of insight as far as Zepbound, Wegovy, and the other indications that they're being used for, other than just obesity, and how you can use these other indications to get your patients this medicine if they're needing it primarily for obesity. Again, majority of our obese patients have sleep apnea. Majority of our obese patients have coronary disease. And so that only makes sense. So that was just a little extra for those two medications. Now, off-label therapeutics, again, these are old medications that we're using off-label. They're not FDA approved for weight management, but we have seen some benefits, and for the most part, they are individually quite inexpensive. Metformin, we all know metformin. We use this primarily for diabetes and sometimes PCOS as well, but also off-label for weight management. Um, the thing to be cognizant about with regards to metformin, again, side effects are diarrhea for the most part, abdominal bloating, and also we need to be cognizant about their renal function when prescribing this medication. Um, Topiramate, as we mentioned earlier, it is with a compounded with another medicine when used for weight management. However, by itself, it's considered off-label. This is primarily a GABA modulator, AMP, glutamate receptor antagonist, and it helps primarily for headaches or seizures. It's primarily a neuroleptic medication, but off-label can be used for weight management as well, and it is quite inexpensive. Again, side effects is that it can cause some somnolence and drowsiness. So we like to give this medicine at nighttime. Um, Also be cognizant about the contraindications, and that not given during pregnancy, as well as closed angle glaucoma and any metabolic acidosis issues. The big one is that we have to keep an eye out for is that it can cause suicidal ideation. So we always ask our patients how they're doing from a mental health standpoint as well. bupropion by itself. This is an inhibition of norepinephrine and dopamine reuptake stimulation. Um, or this leads to appetite suppression. This also, just as a side note, is also used for smoking cessation as well. Um, so um, just wanted to throw that out there. All right. Primarily used for antidepressant. All right, so then we go into hormone replacement therapy, and this is something that you have to obviously find the right patient population for this with regards to hormone replacement therapy. I'm going to primarily be talking about testosterone. So on average, obese men have about 30% less testosterone levels than those who have normal weight. And so we look at that and we try to increase their testosterone to allow them to have more energy to work out and also to help with their metabolism as well. Um, so long-term testosterone therapy in men with testosterone deficiency improves body composition and quality of life, which then can also lead to weight management. Let's see here. The last bullet, testosterone deficiency with or without lifestyle may be very effective and useful in management of obesity. And so this was coming out from the Opinion Endocrinology Diabetes Obesity Journal. Sorry. So I was just told I have a few minutes left. So I wanted to just touch into peptides really quickly. Um, there are two peptides out there, AOD 9604 and MOTS-C. Actually, typos, MOTS-C, that have been shown to be beneficial in um, weight management. And so this is the AOD 9604. AOD stands for anti-obesity drug 9604. It's a fragment of the growth hormone polypeptide. Has been shown to have lipid-lowering effects without the side effects of the unmodified growth hormone. It regulates fat metabolism by stimulating lipolysis and inhibiting lipogenesis. This was done in laboratory testing as well as in animal and human tests. And current studies are being done with AOD to see how it benefits osteoarthritis, hyperlipidemia, bone, and cartilage repair. And this was also, there's some data on this, and I have some journals that this was in as well. So, the way this is administered, it's 250 micrograms subcutaneously twice a day or 300 micrograms daily, taken daily on an empty stomach, 1 hour before a meal. And you treat approximately 6 weeks to up to 6 months, depending on the individual, and then you cycle them off of this. All right. MOTS-C. So MOTS-C is a peptide, 16 amino acids produced by a mitochondrial gene. It has shown to play a role in the signaling and energy production, given that it's coming from the mitochondrial gene. And it's shown to regulate metabolic functions throughout the body, turning glucose into usable energy. And prelim studies have shown that this is improved, has for improved control over blood sugar levels in obese patients, thus decreasing insulin resistance and improving weight loss. The way MOTS-C is administered is 5 milligrams sub-Q 3 times a week for 4 to 6 weeks, followed by 5 milligram weekly doses for 4 weeks. So this is about a 2 week, sorry, a 2 month program, and then you cycle off, and then you can start back up with the 3 times a week dosing. So let's stop here and see if there's any questions. I kind of went over the last bit quickly, but I wanted to kind of get the peptides. I'm really enjoying learning more and more about peptides. There's just so much out there that we can do to help our patients achieve the goals that they want to that they set for themselves.
So currently still no questions in the chat. Going forward, we will try to make it a little easier for listeners to put in questions. Um, I want to thank all of our listeners who stayed with us through this entire lecture. We had a good amount of participation today. Sorry, then, if you want to finish up,
Okay, all right, great. So
just due to
let's,
time
I'll just,
constraints.
sorry.
Just due to time constraints.
Oh, okay, no worries, no worries. If I mean, if we're good with time, I'm fine ending here. Do you? You tell me.
Yeah, we have a few minutes.
Okay. All right. So these are just some real world examples. This is, one patient which came in, no medical issues, weighed about 211 pounds, started on Mounjaro, again, tirzepatide, Mounjaro initially. This was something that she got prior to coming to see me. And this was at the time when Manjaro was being written for anything and everything, and they were being approving it for anything and everything. However, the following year, they became a little bit more strict as to who was able to get Manjaro, given that the patient was not diabetic. They had stricter protocols, and you had to get proper prior authorizations, and was unable to get Wegovy. At the time, in 2023, Zepbound was not approved yet. And so we then tried to get her onto semaglutide Wegovy brand. And um, that's kind of where we attempted. She tried phentermine in the past. It caused palpitations and uneasiness and jitteriness, and she didn't want to do that again. And the cost for her was up to $1,200 a month to get the Wegovy. So we went through a compounding pharmacy, and we were able to get her semaglutide, cyanocobalamin, eventually got her up to a max dose of 2.4 milligrams subcutaneous weekly. And for her, instead of costing her 1,200 a month, it was costing her approximately 300 a month at that dose. And she was 211 pounds and dropped down to 173 pounds after 4 months. She felt much better, was a lot more active, and was doing really, really good. And she did not have any side effects other than some mild nausea, given that she was on the semaglutide. But after a while, that even resolved. So this is just, again, one example of how we use compounding pharmacies to help our patients out. Um, and there's another similar patient to this that was on semaglutide. However, they were not seeing much weight loss on the max dose of semaglutide. So we added AOD to that individual's regimen, and they were able to jumpstart their weight loss after a month of being on AOD, which we phased out, and we cycled off that and just continued with the semaglutide, and that allowed that individual to continue to see changes. So again, it's ever changing. We are not definitely not a practicing cookie cutter medicine where one medication is appropriate for everybody. And so it's just, I think right now it's very exciting when it comes to weight management with our patients.
Yeah, absolutely. I mean, these are some really impressive results. Thank you so much, by the way, for this talk. It was extremely interesting for taking us kind of through the history of obesity medications and where we are now and where we might be in the future with these peptides coming out, which I'll confess I didn't really know much about. So this was definitely something that I learned that was entirely new to me. And I've just been like, researching a little bit here on the side about them. Um, I think as these things grow and physicians have more and more tools at their disposal to fight obesity for their patients, it's critical to kind of be aware of all the tools you have in your toolbox, to kind of think on
Absolutely.
them.
But you have to also be comfortable, with what you're doing, and knowing the potential side effects and harms. But yes, it is definitely exciting to know that there are a lot of new things coming out, a lot of new research occurring. And just like you, as you mentioned, you weren't aware. I recently went down this rabbit hole of peptides, and
Yeah.
it's just really exciting.
Yeah, yeah. And even more so for our communities, a lot of times at Masjid, people will ask you about obesity and how to lose weight. I mean, these are all things that you can mention. You can have people talk to their own PCPs regarding, again, what's out there. And yeah. Thank you so much again. Really,
Well, thank
really
you. I appreciate it.
great talk. Very thorough. I know we were a little pressed for time at the end, but awesome presentation.
No,
And
I
thank
hope
you to all of
your
our listeners.
Saturday evening didn't go wasted.
And thank you to all of our listeners as well. Um, as always, we will post a recording of this on our YouTube channel. أنا شكرا آخر ما دعا करिए कि खुदा ताला हमारा मौला ने क़यामत दिन तक बाकी ने बाकी रखे आमीन.
Um,
Thank you, Adnan bhai.
Thank you, Elizabeth. Bye.